You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about antiplatelets and anticoagulation in the setting of acute coronary syndromes. Upon plaque rupture, platelet adhesion to the subendothelium depends on the interaction between GP1B and 9 receptor complex on the platelet surface and von Willebrand factor, and also between collagen exposed at the site of vascular injury and collagen receptors on the platelet surface. These bindings trigger release of thromboxane A2 or TXA2, adenosine diphosphate or ADP, and thrombin, which further recruit and activate circulating platelets. Clopidogrel, prasugrel, ticagrelor, and cangrelor inhibit ADP binding with the P2Y12 receptor on a platelet surface. The final step in the activation of platelets is conversion of the platelet GP2B3A receptor, the main receptor mediating platelet aggregation, into its active form. Activated GP2B3A receptors bind to fibrinogen and von Willebrand factor, causing platelet aggregation and thrombus formation. Tirofiban, abciximab, and eptifibatide inhibit this pathway by binding to the GP2B3A receptor. Meanwhile, vascular injury also exposes subendothelial tissue factor, which binds to factor 7A and promotes conversion of prothrombin to thrombin, which in turn converts fibrinogen to fibrin, generating a fibrin-rich clot, and further activates platelets by binding to protease-activated receptors, PAR1, on the platelet surface. Heparin and bivalirudin inhibit this latter pathway by binding to coagulation cascade factors. Let's start with the P2Y12 inhibitors. The generic and trade names of P2Y12 inhibitors are clopidogrel, Plavix, prasugrel, Effient, ticagrelor, Brilinta, and cangrelor, Cangrelor. The AJACC 2016 guidelines prefer ticagrelor or prasugrel over clopidogrel as the P2Y12 in ACS, Class 2A. The onset of action is 2 to 8 hours for clopidogrel, 3 to 5 hours for ticagrelor, 30 minutes to 4 hours for prasugrel, and 1 hour for cangrelor. Maximal inhibition from clopidogrel does not occur until at least 6 hours after the 600 milligram loading dose, and even later after the 300 milligram load. Cangrelor's high affinity of binding allows it to immediately inhibit ADP-induced platelet aggregation within the hour. Clopidogrel and prasugrel are irreversible binders of the P2Y12 receptor, whereas ticagrelor and cangrelor are reversible binders of the P2Y12 receptor. Because of irreversible binding at the P2Y, production of entirely new platelets is needed to normalize platelet function. So normalization of platelet function is delayed at least 5 days after clopidogrel administration. Prior to CABG, it is a Class 2A indication that you have to wait 5 days off clopidogrel, which is an irreversible binder, 7 days off prasugrel, which is an irreversible binder, 3 days off ticagrelor, which is a reversible binder, and 1 hour off cangrelor, which is a reversible binder. In antiplatelet naive patients undergoing elective CABG who have never been on aspirin before, do not initiate aspirin in the 24-hour pre-op period because it causes increased bleeding risk. But if they have it, you should continue it. Out of the P2Y12 receptor inhibitors, prasugrel causes the most fatal bleeding, including intracranial bleeding, whereas clopidogrel causes the least elevated risk of bleeding, and ticagrelor is in the middle. Prasugrel is contraindicated in patients with history of stroke or TIA because it causes harm, increased major bleeding in this subgroup. Weight less than 60 kilograms and age of 75 or more don't have increased harm from prasugrel, but there is no benefit in them. Opioids will slow gastric emptying, decrease gastric secretions, and delay absorption of all P2Y12 inhibitors, so you need to be aware of that. The ACS loading dose for clopidogrel is 600 milligrams once, followed by 75 milligrams daily. The loading dose for ticagrelor is 180 milligrams once, followed by 90 milligrams BID for 1 year post ACS, then down to 60 milligrams BID. The loading dose for prasugrel is 60 milligrams once, followed by 10 milligrams daily. The loading dose for cangrelor is 30 micrograms per kilogram IV, followed by 4 micrograms per kg per minute infusion. The guidelines do not recommend upfront loading of a P2Y12 inhibitor in patients being taken to the cath lab as part of an early invasive strategy, i.e., no need to load the P2Y12 inhibitor on the floor, or ED. Once coronary angiography has defined anatomy of the lesions and it becomes clear whether the patient should get PCI or CABG, then the P2Y12 inhibitor can be chosen and administered. But for patients being rushed to the cath lab as part of a STEMI, the P2Y12 inhibitor should be loaded up front. Ticagrelor-associated dyspnea occurs in 15% of patients, and which goes away after discontinuing ticagrelor or switching to a different P2Y12 inhibitor. Ticagrelor can also cause ventricular pauses, which are typically asymptomatic. What does the 2021 ACC/AHA SKY guideline for coronary artery vascularization say about P2Y12 inhibitors and aspirin in patients undergoing PCI? In patients undergoing PCI, a loading dose of aspirin followed by daily dosing is recommended to reduce ischemic events. That's a very obvious class 1 recommendation. In patients with ACS undergoing PCI, a loading dose of P2Y12 inhibitor followed by daily dosing is recommended to reduce ischemic events, class 1. In patients with stable ischemic heart disease, which has now been renamed chronic coronary disease, undergoing PCI, a loading dose of clopidogrel followed by daily dosing is recommended to reduce ischemic events, class 1. In patients with PCI within 24 hours after fibrinolytic therapy, a loading dose of 300 milligrams clopidogrel followed by daily dosing is recommended to reduce ischemic events, class 1. In patients with ACS undergoing PCI, it is reasonable to use ticagrelor or prasugrel in preference to clopidogrel to reduce ischemic events, including stent thrombosis, class 2A. In patients less than 75 years of age who are undergoing PCI within 24 hours after fibrinolytic therapy, ticagrelor may be a reasonable alternative to clopidogrel to reduce ischemic events, class 2B. In patients undergoing PCI who have a history of stroke or transient ischemic attack, prasugrel should not be administered, class 3 harm. In patients undergoing PCI who are P2Y12 inhibitor naive, intravenous cangrelor may be reasonable to reduce periprocedural ischemic events, class 2B. Now let's move on from the P2Y12 inhibitors to GP2B3A inhibitors. The generic and trade names of GP2B3A inhibitors are abciximab, RioPro, eptifibatide, integralin, and tirofiban, aggrastat. The reduction in clinical events from GP2B3A inhibitor use is achieved in the first 48 hours, with little separation of event rate curves after that time. They do not have any long-term effects in reducing rates of restenosis. Tirofiban, an intravenous small molecule inhibitor of the GP2B3A complex that interacts with VWF and fibrinogen to cause platelet aggregation, is the most potent inhibitor of platelet function because it blocks aggregation stimulated by all agonists. Tirofiban has a rapid onset of action on the order of minutes. Tirofiban reversibly binds to the GP2B3A receptor, so platelet function returns to normal within 6 to 8 hours of stopping the infusion. Eptifibatide and tirofiban, which are GP2B3A inhibitors, have a class 2B indication for patients treated with an early invasive strategy and that with intermediate or high risk features. Thrombocytopenia can occur within minutes to hours after starting GP2B3A due to preformed natural antibodies as part of drug-induced immune thrombocytopenia. You have to distinguish this from pseudothrombocytopenia, which is a lab artifact of no clinical consequence. EDTA, that is in a lab collection tube, causes platelet agglutination, so you should send the blood sample in a citrate tube. What does the 2021 ACC/AHA SKY guideline for coronary artery vascularization say about GP2B3A inhibitors in patients undergoing PCI? In patients with ACS undergoing PCI with large thrombus burden, no reflow, or slow flow, IV GP2B3A agents are reasonable to improve procedural success. That's a class 2A indication. In patients with stable ischemic heart disease, now renamed chronic coronary disease, undergoing PCI, the routine use of an intravenous glycoprotein 2B3 inhibitor agent is not recommended. Class 3. Now let's move on from the GP2B3 inhibitors to the coagulation cascade inhibitors. Low molecular weight heparins are derived from unfractionated heparin through chemical or enzymatic depolymerization. The shorter molecules of low molecular weight heparin contain the critical pentasaccharide sequence necessary for binding and activating antithrombin. When heparin binds to antithrombin undergoes a conformational change that results in inactivation of thrombin, which is factor 2A and factor 10A. Fondaparinux only inhibits factor 10A. Bivalirudin only inhibits factor 2A. Unfractionated heparin inhibits both factor 10A and 2A in a 1-to-1 ratio, while enoxaparin inhibits factor 10A and 2A in a 3-to-1 ratio. PTT, which is used in unfractionated heparin monitoring and bivalirudin monitoring, does not get affected by low molecular weight heparin, so PTT is not useful in monitoring a low molecular weight heparin. Although the anticoagulant effect of low molecular weight heparin can be determined by measuring anti-factor 10A activity, the stable pharmacokinetics of low molecular weight heparin makes it unnecessary to measure levels, except in patients who are obese or have renal impairment when there is uncertainty about sub or supratherapeutic levels. Compared to unfractionated heparin, low molecular weight heparin is less likely to lead to type 2 heparin-induced thrombocytopenia. However, once HIT occurs, low molecular weight heparin should be avoided just as unfractionated heparin is avoided. Bivalirudin is safe to use in patients with a history of HIT. Heparin cannot be absorbed by the GI tract and has to be administered either intravenously or subcutaneously. The bioavailability of subcu heparin is only 30%, whereas the bioavailability of subcu low molecular weight heparin is 90%. So, subcu heparin is only used for DVT prophylaxis. If therapeutic doses are needed, IV heparin or subcu low molecular weight heparin is used. Other than unfractionated heparin for 48 hours or until a left heart cath is performed, the other options for anticoagulation in ACS are enoxaparin subcutaneous therapeutic dose, that's low molecular weight heparin, for the duration of hospitalization or until left heart cath is performed. Bivalirudin, which is only for early invasive strategy patients until left heart catheterization. Bivalirudin is used in patients who have heparin-induced thrombocytopenia. Or fondaparinux for the duration of hospitalization or until left heart catheterization. If you use fondaparinux, at the time of PCI, you need to give unfractionated heparin or bivalirudin due to the risk of catheter thrombosis. In a large meta-analysis, enoxaparin led to lower rates of recurrent MI compared to unfractionated heparin with similar rates of bleeding. The dose of enoxaparin subQ for STEMI prior to PCI is, if aged less than 75, then there is a loading dose. If creatinine more than 30, you give a 30 milligram loading dose, followed by 1 mg per kg for subcutaneously every 12 hours. If creatinine clearance is less than 30, you still give the 30 milligram IV loading dose, followed by a 1 mg per kg subcutaneous every 24 hours instead of 12 hours. This is the dose of Lovenox or enoxaparin subQ for STEMI prior to PCI. If the age exceeds 75, then the loading dose is foregone. You just go straight. If the creatinine clearance is more than 30, you give 0.75 mg per kg subcutaneous every 12 hours. If the creatinine clearance is less than 30, you give 1 mg per kg subcutaneous every 24 hours. If the last dose of enoxaparin was less than 8 hours prior to PCI, you can just go to PCI. If the last dose of enoxaparin was 8 to 12 hours prior to PCI, or the patient only received one subQ dose, then give 0.3 mg per kg IV of the enoxaparin. If the last dose of enoxaparin was more than 12 hours prior to PCI, give the next scheduled dose. In practice, I feel that I've not really seen enoxaparin used that much as a substitute for heparin, except when there's a specific reason to avoid heparin. So in practice, I feel that piece of information may not be as necessary to know. The dose of bivalirudin enoxaparin requires adjustment in renal insufficiency, but the dose of unfractionated heparin does not. In patients who are unable to take heparin due to allergy, religious reasons, or heparin-induced thrombocytopenia, you can give bivalirudin. But this is only approved for early invasive strategy patients, the ones you're cathing in 3 to 24 hours. Bivalirudin also has less bleeding risk than heparin, and it is a direct thrombin inhibitor. It binds directly to thrombin without requiring antithrombin. Because it is cleaved once bound to thrombin, bivalirudin has a very short half-life. Now let's take a look at what the 2021 ACC/AHA SKY guideline for coronary artery vascularization says about coagulation cascade inhibitors in patients undergoing PCI. In patients undergoing PCI, administration of intravenous unfractionated heparin, UFH, is useful to reduce ischemic events. That's a class 1 recommendation. In patients with heparin-induced thrombocytopenia undergoing PCI, bivalirudin or argatroban should be used to replace unfractionated heparin to avoid thrombotic complications, class 1. In patients undergoing PCI, bivalirudin may be a reasonable alternative to unfractionated heparin to reduce bleeding, class 2B. In patients treated with upstream subcutaneous enoxaparin for unstable angina or non-ST elevation ACS, the use of intravenous enoxaparin may be considered at the time of PCI to reduce ischemic events, class 2B. In patients on therapeutic subcutaneous enoxaparin in whom the last dose was administered within 12 hours PCI, unfractionated heparin should not be used for PCI and may increase bleeding, class 3 harm. That's a wrap for our episode on antiplatelets and anticoagulation in the setting of ACS.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.